quý vị đại biểu, Eisai là công ty nằm trong top 10 các công ty dược phẩm hàng đầu tại Nhật Bản. Với triết lý HHC Human Healthcare, phương châm hoạt động của công ty Eisai luôn hướng tới vì lợi ích sức khỏe của bệnh nhân và gia đình của họ. Đại diện công ty Eisai, tôi xin chân thành cảm ơn Hội Khoa học Tiêu hóa Việt Nam đã tạo điều kiện cho công ty Eisai được đồng hành với hội để tổ chức buổi hội thảo vệ tinh ngày hôm nay. Đặc biệt xin chân thành cảm ơn sự tham gia quý báu của ban chủ tọa và báo cáo viên của chương trình. Tại đầu cầu Hà Nội, tôi xin trân trọng giới thiệu ban chủ tọa của chương trình, giáo sư tiến sĩ bác sĩ Đào Văn Long, Phó Chủ tịch Hội Khoa học Tiêu hóa Việt Nam, Phó giáo sư tiến sĩ bác sĩ Vũ Văn Thiên, Tổng thư ký Hội Khoa học Tiêu hóa Việt Nam, báo cáo viên tiến sĩ bác sĩ Đào Việt Hằng, Phó Giám đốc Trung tâm Nội soi Bệnh viện Đại học Y Hà Nội, Phó Tổng thư ký Hội Khoa học Tiêu hóa Việt Nam. Và tại đầu cầu Mỹ, tôi xin trân trọng giới thiệu giáo sư tiến sĩ bác sĩ Ronnie Fass, Đại học Case Western Reserve, trưởng khoa tiêu hóa gan mật, Giám đốc Trung tâm Sức khỏe Tiêu hóa Metro Health Ohio, Mỹ. Kính chúc quý vị đại biểu sẽ có buổi trưa cập nhật nhiều kiến thức hữu ích từ bài giảng của quý báo cáo viên. Sau đây, tôi xin trân trọng kính mời giáo sư tiến sĩ bác sĩ Vũ Văn Thiên. Thầy sẽ phát biểu khai mạc chương trình, cũng như đồng chủ tọa cùng với giáo sư Đào Văn Long để phối hợp điều phối nội dung hội thảo ngày hôm nay. Trân trọng kính mời thầy.
Kính thưa giáo sư tiến sĩ Đào Văn Long, chủ tọa cùng với tôi, kính thưa tất cả các thầy cô. Như vậy là bây giờ là buổi ăn trưa thì nó cũng có tiến hành rồi, thì các thầy các cô thì ai có thức ăn này chúng ta đã ăn được trước rồi, và bây giờ cái phiên hội thảo hôm nay thì cái phiên hội thảo của chúng ta thì là một cái chủ đề rất là hay và quan tâm từ trước đến nay, đó là bệnh lý trào ngược dạ dày ngoài thực quản. Hôm nay tôi xin giới thiệu về cái chuyên đề này thì đã được session này được công ty Eisai tài trợ như ban đầu đã nói. Trên bảng thì chúng ta đã biết, show cái hình của tôi thì giáo sư Ron Phát, chúng tôi xin giới thiệu luôn. Giáo sư Ron Phát là một giáo sư hết sức nổi tiếng. Show hình của giáo sư Ron Phát hết sức nổi tiếng ở trên thế giới. Người đã đưa ra cái đồng thuận ROM 4 về vấn đề về bệnh trào ngược dạ dày trên thực quản. Và tôi được biết hiện nay giáo sư đã sang Việt Nam 2-3 lần rồi và cũng đã trình bày cái bài ngày hôm nay. Và đồng thời giáo sư thì cũng là cái người là báo cáo rất nhiều ở trong cái hội nghị quốc tế. Và hôm nay chúng tôi hy vọng là giáo sư Ronnie Phát sẽ trình bày về cái bệnh lý trào ngược ngoài dạ dày thực quản, các cái quan điểm của điều trị. Người thứ hai chúng tôi xin giới thiệu đó là tiến sĩ Đào Việt Hằng, hiện nay là phó giám đốc trung tâm của Viện Nghiên cứu Đào tạo Tiêu hóa gan mật, một bác sĩ rất trẻ nhưng mà rất là nhiệt huyết, rất có nhiều kinh nghiệm, trình độ ngoại ngữ rất là tốt và có khả năng diễn thuyết cũng như trình bày nhiều bài báo rất là hay. Tiến sĩ Đào Việt Hằng sẽ trình bày về vấn đề sử dụng Parodontic cho những cái bệnh nhân là viêm dạ dày ở tay trang. Tiếp theo thì mở đầu chương trình chúng tôi sẽ xin trân trọng kính mời giáo sư Ronnie Phát từ trường đại học Arizona của Mỹ sẽ trình bày về một cái chủ đề về là GERD ngoài thực quản. Chúng ta sẽ xem video record. Chúng tôi xin trân trọng cảm ơn. Xin mọi người lắng nghe.
Hello, everybody. Hello, Vietnam. I'd like to thank the Vietnamese Gastroenterological Association for inviting me to give this very interesting topic. My name is Ronnie Fass. I'm a professor of medicine at Case Western Reserve University. And I will cover the topic extraesophageal and atypical manifestations of gastroesophageal reflux disease, appropriate recognition and treatment. Before we start my presentation, I'd like to emphasize that there is still no approved treatment for any of the atypical and extraesophageal manifestations of gastroesophageal reflux disease in 2021. And this is despite an extensive research in the area of gastroesophageal reflux disease and marked improvement in the different therapeutic modalities, medical, surgical, and endoscopic. Still, no approved indication for any of these disorders. And the question is, why? Why we're still devoid of approved medications? So first of all, it's not clear that atypical and extraesophageal manifestations of GERD are separate diseases that require specific indication. Maybe they're just part of the GERD manifestations, or maybe not. So that hasn't really resolved. Another problem is lack of standardization of all the diagnostic tests that we have for these disorders. So it's not clear which one to use, which test should be the standard of care. That still remains an area that has not been resolved yet. Disappointing therapeutic trials. So there were some big trials, and I will review a few of them that were done. They did not show any improvement in symptoms despite proper design of the trial. And there's been limited progress in understanding the mechanisms behind atypical and extraesophageal manifestations of GERD. Although I will mention at the end of my presentation a new area, especially the topic of cough hypersensitive syndrome, that maybe would be kind of a breakthrough in the area of atypical and extraesophageal manifestations of GERD. So let's start with atypical chest pain or non-cardiac chest pain. So it's very clear that some of the patients with gastroesophageal reflux disease will have heartburn as their sole symptom. Maybe they will have also regurgitation and other symptoms. But the primary symptom is really heartburn. But it's also clear that other patients with GERD will have chest pain as the only symptom and the sole symptoms. But to make it more complex, we do know that most of the patients have a combination of the two. They have heartburn and chest pain as a result of reflux events. And obviously the question is, why sometimes they develop heartburn as a result of reflux events and other times they develop chest pain? Now, what are the mechanisms for chest pain in patients with gastroesophageal reflux disease? And as you can see from the long list, it's not really clear. There are many suggestions, many studies that have proposed different type of mechanisms. One of them, that there is a decreased flow in the coronary circulation that leads to a phenomenon of ischemic heart disease, what is called link angina. And the concept here that reflux into the esophagus through vagal reflex leads to contraction or spasm of the coronary arteries that lead to kind of an ischemic pain. There are others suggested that it depends really on the characteristics of reflux episodes. And there is no necessarily that stimulus in the esophagus lead to a specific symptom. So that means that if somebody gets reflux, they have to have only heartburn. It could be that they develop other symptoms like chest pain. And they suggested that the chest pain may appear in situations where patients get exposed to low pH over longer duration. Another study suggested that the problem is not really at the mucosal level, but at the level of the longitudinal muscle of the esophagus, the outermost muscle of the esophagus. And they've shown that in response to reflux, there is a sustained longitudinal muscle contraction. So the muscle contracts over a longer period of time. And they've noticed that when the muscle contracts over a certain period of time, patients move from heartburn to chest pain. Which brings to another hypothesis suggested that maybe these contractions of esophageal muscles may lead to reduced esophageal blood flow, and that will result in local ischemia and then lead to pain. Others suggest that symptoms in the esophagus are just not stimulus specific, that patients maybe have esophageal hypersensitivity due to acidic sensitization to repeat acid exposure that leads to increased sensitivity, and that increased sensitivity predisposes the patients to develop symptoms like chest pain. And then last but not least, esophageal hypercontractility, that patients with non-cardiac chest pain as a result of reflux may develop hypercontractility of the esophagus, which is associated with chest pain, because now it becomes some type of esophageal function abnormality or motor abnormality. One of the problems, and I will point out to many of these issues in my presentations, is that we're still lacking proper classification of atypical and extraesophageal manifestations of GERD. The area is pretty much chaotic at this point, and it's not clear what is the proper classification. Now, as you all remember the Montreal classification, they tried to put some order in the area of atypical and extraesophageal manifestations of GERD. So if you look at the Montreal consensus under the topic of extraesophageal syndrome, they actually divided them to establish the association, that there's sufficient evidence in the literature to suggest that there is an association, although the extent of causality is not known. Various versus proposed association, where it's not clear if there is association at all, although there are studies to suggest it. So under established association, there was the reflux cough syndrome, reflux laryngitis syndrome, reflux asthma syndrome, reflux dental erosion syndrome. And the others, like pharyngitis, sinusitis, and others, esophageal symptoms and signs, they fell under the category of proposed associations. They also put, for the first time, chest pain under esophageal syndromes, under symptomatic syndromes, rather than an atypical manifestation of GERD. They did not think it was atypical, and they called it as a typical esophageal syndrome. They called it reflux chest pain syndrome. However, as you could see, the Montreal consensus touched really on a very small number of extraesophageal manifestations that have been mentioned in the literature. And I just put here on a slide a limited number of signs and symptoms that have been proposed to be related to gastroesophageal reflux disease. None of them, as you could see, none of them is even mentioned in the Montreal consensus, again, suggesting that we are still devoid of proper classification and trying to put this large group of disorders in a certain clear order and classifications. Another problem is that when we have a patient with a proposed extraesophageal or atypical manifestation of GERD, and we find that the patient has reflux, the question is, what is the degree of the true relationship between this atypical or extraesophageal sign or symptom and the GERD that we find in the patient? Are they related? If they are, to what extent? We don't know that. Many times, because we see that the patient has erosive esophagitis or abnormal pH test, and they also have cough, we make the assumption that the two are related. But that's not the case many times, as we see when we start to treat those patients. Now, in relation to the pathophysiology of extraesophageal manifestations, there are many theories, but I'll touch only the two main ones. The first one is the reflux theory. And this suggests that reflux through esophageal sphincters, especially through the upper esophageal sphincter, that reflux reaches the pulmonary system, the larynx, pharynx, oropharynx, and leads to symptoms. So this reflux theory suggests that there is a direct contact of gastric refluxate with tissue in the bronchial tree or in the oropharynx and larynx. Then there is the reflex theory, suggesting that there is not really a need for reflux to reach all these extraesophageal organs. But through a vagal reflex, they can stimulate a response of these organs, like a response in the bronchial tree, a response in the larynx or the pharynx. And this comes from the principle that we do know that there is a common embryonic origins between the esophagus and the bronchial tree. Now, when we look at causes of chronic cough, you can see that gastroesophageal reflux disease is not the number one. It's not even the second one. So the most common cause of chronic cough is postnasal drip, followed by asthma. And only the third most common cause is gastroesophageal reflux disease. Although many times when patients develop chronic cough, they end up in GI. So you have to remember that most of the cases for chronic cough are not GERD related. If we look at the causes of chronic cough as it is related to patients' age, we can see that in children, asthma is the most common cause, followed by postnasal drip. In adults, it's postnasal drip followed by asthma. And in the elderly, it's postnasal drip followed by GERD. Now, this is a study, this is a systematic review, and they showed that there is an association between gastroesophageal reflux disease and asthma. And in this study, they showed that the larger the sample size, the higher the likelihood that there is evidence for a relationship and association between GERD, different manifestations like erosive esophagitis, abnormal pH, positive symptoms or the presence of Yale hernia, and patients having asthma. This is another study that showed again that patients that have erosive esophagitis or esophageal stricture are more likely to have a variety of extraesophageal manifestations. And you can see the long list. They have a 60% increased risk of having sinusitis, 48% increased risk of having pharyngitis, 51% increased risk of having asthma, 26% increased risk of having bronchiectasis, and others. So all of these studies do show an association. They don't demonstrate causality, but they do demonstrate an association between gastroesophageal reflux disease and extraesophageal manifestations of GERD. There are certain clues that we can have in our practice that may suggest that GERD is the underlying cause of the extraesophageal or atypical manifestation that we evaluate in our patient. And here are some of the tips or some of the clues. The first one is that it's adult onset. So it's less likely if somebody had asthma as a kid and that which continues to the adult, that this was GERD all along. But if somebody as an adult developed asthma, then GERD should be looked at. Heartburn and regurgitation that precede the extraesophageal symptom. If the patient develops heartburn or regurgitation, and then after that starts to have cough or starts to have other manifestation, that may be suggestive of a true relationship. Nighttime symptoms, very classic, and many studies have shown that nighttime extraesophageal manifestations should be considered to be related to GERD. because this is the supine position, which patients with GERD are more prone to have reflux in. Symptoms refractory to routine therapy, so whatever usually treats that extraesophageal manifestation, for example, asthma, treated with inhalers, steroids, whatever, and still there's no response, so it's refractory asthma, then one has to consider GERD as the potential cause. And then symptoms that are exacerbated by meals, exercise, or the supine position. In other words, anything that exacerbate GERD and exacerbate these extraesophageal manifestation, then one should consider that maybe the two are related. This is going back to the same study, and they do show that there is a severity-response relationship between symptoms of gastroesophageal reflux disease and asthma, further cementing the association between the two. They're able to show that the more frequent is the gastroesophageal reflux disease, that the higher the likelihood the patient will report asthma. That suggests a positive association between the two. So another issue that we have is we're still unable to identify diagnostically who are the patients with true relationship between an atypical and extraesophageal sign or symptom and gastroesophageal reflux disease. So it's still an issue for us to determine diagnostically if what I see in the esophagus is what causes the problem in the larynx, pharynx, or pulmonary system, or what I see in the larynx, pharynx, or pulmonary system is classically and related to the GERD that patients might have. And what happened is that we have a kind of a situation where we have enthusiastic ENTs that see a lot of GERD when they evaluate patients, especially if they don't find any other reason for their laryngeal, pharyngeal symptoms. And so they proposed that it might be related to GERD, or they say that it's related to GERD. And then these patients end up in GI. And we are now stuck with patients where it is not really clear that their extraesophageal symptom is truly related to GERD at all. But they were sent already to us, and they were referred to us by a specialized person who clearly told the patient it is related to GERD, and the patient's expectations are accordingly. So there is a dichotomy here, and that hasn't been breached over the years. Actually, it's gotten worse in my mind. And the question is, when the ENT, they look at the larynx using laryngoscopy, they use, as I'm going to show you, very insensitive parameters to make the diagnosis of GERD that involves the larynx or the pharynx. For example, if you look at GERD probability, as you move from the left to the right, then GERD probability decreases. So if patients have contact ulcers, granulation, or nodules in their larynx, they have a high probability that GERD is the underlying cause, subglottic stenosis or polyps. But as you reach edema and erythema, then the GERD probability is markedly decreased. Unfortunately, edema and erythema are the most common diagnostic terms that are used by ENT in order to determine that patients have GERD-related extraesophageal manifestation. So the most insensitive findings are used to make the diagnosis. Here's another study looking at academic centers or community-based centers. And they've shown that in both of these organizations, edema and erythema, non-specific signs, are the most commonly used or relied upon in order to make the diagnosis that patients have GERD-related laryngeal manifestations. Again, further exacerbating the disconnect between ENT and GI. In fact, when we look at patients that are referred to us for potential laryngeal manifestations of GERD and we perform endoscopy, then these are the potential things that we're looking for. Non-erosive reflux disease, esophagitis, Barrett's. We're looking for any of these. Well, if you look at overall studies, then we found out that in more than 80% of the cases, the endoscopy will be normal in these patients. In only about 19%, there will be erosive esophagitis, and mostly grades A and B, which today the Lyon consensus meeting do not even consider them as inconclusive of GERD, although I have some issues with grade B. And then no studies showing that these patients have Barrett's esophagus. So one of the things that clearly starts to show up is the fact that in most of these patients, we don't have evidence that they have gastroesophageal reflux disease, clearly suggesting that we get a lot of patients from referring physicians, like from ENT, pulmonary, of patients they suspect that they might have GERD as their underlying cause, and these patients don't have GERD. This is another study looking at evaluation of patients with laryngeal symptoms and suspected laryngopharyngeal reflux with pH impedance, and it's positive only in 47%, negative in 38%, and 15% equivocal. So it's almost like tossing a coin. That's the likelihood that the test will be positive in these patients. So again, the likelihood that each upper endoscopy will be negative in patients that refer to us with laryngeal manifestations that were presumed to be related to GERD is more than 80%. That pH on therapy will be normal in more than 90%. That impedance pH on BID therapy, normal findings is 70%, and off PPI therapy, it's 60%. So these are some of the diagnostic recommendations of the ACG guidelines. A diagnosis of reflux laryngitis should not be made based solely upon laryngoscopy findings. So I covered this topic. A PPI trial is recommended to treat extraesophageal symptoms in patients who also have typical symptoms of GERD. So one of the things that have been noticed is that if patients also report of GERD-related symptoms like heartburn or regurgitation, that it increases the risk that the two are related. Upper endoscopy is not recommended as a mean to establish a diagnosis of GERD-related asthma, chronic cough, or laryngitis. Reflux monitoring should be considered before a PPI trial in patients with extraesophageal symptoms who do not have typical symptoms of GERD. And non-responders to a PPI trial should be considered for further diagnostic testing and are addressed as refractory GERD. And obviously the suggestion is to perform impedance plus pH in these patients on treatment. Now, what about treatment? So high quality therapeutic trials, some of them were unable to demonstrate superiority of PPIs over placebo in many atypical or extraesophageal manifestations of GERD. I have to emphasize, not all of them, but there were some high quality trials that did not make it. I'll show you some they did. They did not make it. I'll show you some they did. This is one of the most famous trials. Patients with laryngopharyngeal reflux, LPR, that were referred by ENT, and who claimed that these patients have clearly evidence of LPR. They were randomized to esomeprazole 40 milligram twice a day or placebo, and patients were treated over a period of 4 months. When they looked at symptom resolution after 4 months, there was no statistically significant difference between the placebo and the treatment group. And when they loosened the clinical endpoints, so they made it less strict, they called it symptom improvement, so they allowed the patient to have some symptoms. In fact, placebo did a little bit better than esomeprazole. So this study was a negative study. Here you can see again how esomeprazole and placebo looked over the 4 months period of the study, where you can see that there was no difference in response between these two groups. However, we do have some positive studies. Just to show you, this is a study looking at comparing the effect on intragastric pH, comparison between omeprazole and rabeprazole. One looking at duration in hours, where the pH in the stomach was kept above 4, and the other one looked at the mean pH. And you can see that on the first day and 8th day, rabeprazole was significantly better than omeprazole in keeping intragastric pH above 4, and also in maintaining a high mean pH that was above 4. This is a study where patients with LPL, laryngopharyngeal reflux, were randomized to rabeprazole or placebo. This was a 3-month trial, and at the end of 3 months, patients were taken off medication and they were followed to see what happened to the symptoms. The study here was using the reflux score index or reflux symptom index, and they were able to show that there was a significant reduction in the RSI during the treatment period, and when treatment was discontinued, the patient went back to baseline from the symptom point of view, clearly demonstrating that there was a significant improvement in symptoms in those that received rabeprazole versus placebo. This is another study looking at reflux symptoms index and reflux finding score in patients with laryngopharyngeal reflux receiving rabeprazole, again showing a significant improvement after 3 months of treatment. So where does it leave the patient in 2021? And I would say, I left here 2019, and I'm going to show you where it is in 2021. So in 2019, where Dr. Vaezi came with what he called the Vaezi chaotic model, suggested that there's really patients are bouncing from one subspecialty to another in trying to figure out what they have. Primary care send them to GI or send them to subspecialties like pulmonary allergy, ENT. They say, well, the patient have GERD, send them to GI. GI don't think that they have GERD, send them back to pulmonary, ENT, and allergy. They send them to the primary care. And really, there is no resolution. And so this was his model that he came up with in 2019. But I want to bring you to a different situation. So I want to give you a case. So I have a 48-year-old female that presents for evaluation of chronic cough and throat clearing. She reports both symptoms for the last 6 years, denies any baseline heartburn or regurgitation. Pulmonary and sinus evaluations were normal. ENT evaluations suggested laryngopharyngeal reflux. So now she's got the diagnosis of LPR, laryngopharyngeal reflux, and obviously she's referred to GI. GI evaluation, including upper endoscopy, high resolution esophageal manometry, wireless pH capsule, off PPI, were all unremarkable. No evidence of GERD. And then patients was treated with different PPIs during the last year, including BID dosing, and she said no response. So the question is, what am I going to do with this patient? Because ENT clearly claims that this is GERD related. We cannot find anything related to GERD in this patient. And so where is this patient going to go? So this is 2021, and I think we start to see a growing number of studies looking at a concept called cough hypersensitivity syndrome. And what is it? So it is defined as troublesome coughing triggered by low level of thermal, mechanical, or chemical exposure. So there's something that sensitizes the larynx or the bronchi. Also encompasses other symptoms or sensations such as laryngeal hypersensitivity and nasal hypersensitivity. So it's not necessarily involving only the bronchi, but it involves the larynx and even the nasal passages. The pathophysiology of this cough hypersensitivity syndrome, or CHS, that it's an enhancement of the afferent pathways of the cough reflex, both at the peripheral and central level. So there is a hypersensitivity, bronchial hypersensitivity, laryngeal hypersensitivity. And it is caused by some event that lead to it. Almost the same thing that we see in esophageal hypersensitivity. Mechanism involved include the interactions of inflammatory mechanisms with cough sensors in the upper airways and with neuronal pathways of cough associated with a central component. And so there were several studies that looked at neuromodulators in these patients. So there are two randomized controlled trials, two prospective cohorts using amitriptyline for 21 days or gabapentin, two retrospective trials using amitriptyline and pregabalin, and two case reports of gabapentin and baclofen. And you can see the doses on the slide. This is one of the important studies because it's a double-blind placebo-controlled trial, 62 patients. All of them were identified as having the syndrome with a history of refractory chronic cough. And these patients were randomized to gabapentin or placebo with maximum dose of 1,800 milligram QHS, which is a high dose. And various clinical endpoints were assessed, and in all of them, patients markedly improved while they received the gabapentin as compared to placebo. That was statistically significant. Which brings me to the end of my presentation, and I'd like to finish with a very, very provocative suggestion. Maybe it's time that in Rome 5, we will have also functional laryngeal disorders, because many of these patients that come to us have a functional laryngeal disorder. We've already identified several of these disorders. Cough hypersensitivity syndrome, which I just mentioned. I did not talk much on laryngeal hypersensitivity, but it's similar concept. Nasal hypersensitivity, and potentially even get globus as part of it. And how about this definition? No evidence of structural disease, symptoms present during the last 3 months, onset at least 6 months before diagnosis. You have to exclude GERD and no motility disorders. Here you have it. Anyway, I would like to thank you for giving me the opportunity to present my slides and have a great meeting. Thank you.
Okay. Thank you very much for your lecture from Professor Van Ronifat. I think you have got many experience to treatment in patients with extra GERD. And as the topic, we have a question and answer. Thank you very much. Như vậy thì chúng ta đã rất là cảm ơn giáo sư Ronifat đã có một cái bài trình bày rất là hay về vấn đề quan điểm điều trị đối với GERD ở ngoài thực quản. Và trong cái slide cuối cùng của ông ấy thì ông có nói về vấn đề về cái quan trọng nhất là cái ROM 5. Thì chúng ta đã thấy cái ROM 5 bắt đầu đã ra đời, và trong đó có một cái bệnh gọi là tăng nhạy cảm ở vùng hầu họng thực quản. Cái này nó sẽ đưa ra trong thời gian tới. Tí nữa chúng ta sẽ có câu hỏi và liên quan nữa. Thì tiếp theo vì thời gian ấy, chúng tôi xin trân trọng và kính mời tiến sĩ Đào Việt Hằng sẽ trình bày về quan điểm về prophylactic trong điều trị viêm dạ dày mạn.